Good evening and welcome to the National Pancreas Foundation's 2021 Virtual Education Series. I'm Trish O'Neill, the National Director of Chapter Development for NPF. The National Pancreas Foundation provides hope for those suffering from pancreatitis and pancreatic cancer through funding cutting-edge research and advocating for new and better therapies and providing support and education for patients, caregivers, and healthcare professionals. Some of our featured programs include the animated Pancreas Patient, state chapters that assist with education, fundraising, and patient support groups, and our physician programs, which include research grants, medical education, and our annual Fellow Symposium. Our success depends on the support of many individuals and organizations. You can make a difference by joining NPF as a volunteer, making a donation, or sharing your own personal story. For more information on how to get involved, please email us at info@pancreasfoundation.org. Tonight, our program will cover the advancement in the treatment of pancreatic cancer, surgery, and post-surgery options. Please use the Q&A section of the webinar to ask your questions, and Dr. Gilbert and team will address those at the end of tonight's program. Our moderator this evening is Dr. Erin Gilbert. Dr. Gilbert is an associate professor of surgery at the Oregon Health and Science University. She specializes in minimally invasive solid organ surgery with a strong focus on the management of pancreatic disease. Her research interests include the use of advanced MRI techniques in the imaging of pancreatic cancer. She is also passionate about pancreatic cancer surveillance. Dr. Gilbert also serves as the NPF's medical director for the Oregon chapter. Thank you, Dr. Gilbert, for leading our discussion this evening and your team for supporting the mission of the National Pancreas Foundation. Thank you.
Thank you so much, Trish, for not only that kind introduction, but the opportunity to participate in this educational conference. But I'd like to say first, on behalf of myself and our esteemed speakers, what an honor it is to be able to partner with the National Pancreas Foundation. It's such patients and clinicians, but also research scientists, and not just for pancreatic cancer, but for all pancreatic disease. Here in Oregon, we have a long history of being passionate about pancreatic disease and pancreatic health. And I think this partnership, although it is fairly new, I think it's going to be brilliant and longstanding and an important part of what we can offer our start by Amanda Bryant. Amanda Bryant is a registered dietitian specialist who is board certified in oncology nutrition at Oregon Health and Science University, or OHSU, here in Portland, Oregon. Ms. Bryant has been a registered dietitian for 13 years with emphasis in oncology care. She specializes in gastrointestinal cancers and supports patients throughout the continuum of their cancer care. Tonight, Ms. Bryant will be talking to us about the nutritional challenges after the Whipple procedure.
Thank you for that introduction, Dr. Gilbert. I am so happy to be here, and I'm going to pull up my presentation here. Bear with me. Okay. So, share screen. All right, so today's presentation that I'm going to go over is catching, hopefully, with talking about poop. This is an important topic that I try to help patients not shy away from. And so we're going to talk about the nutritional challenges after a Whipple procedure. All right, so let's get started. So what we're going to cover today is the overview of changes after a Whipple procedure. We're going to identify what's called exocrine pancreatic insufficiency symptoms and why is poop so important to talk about. And then, of course, recommendations for nutritional challenges after surgery. I know we only have a short period of time, but we will cover everything we can. So let's go over the normal digestive system before surgery, just to get a before and after. So before surgery, what you eat goes into your stomach, empties into your small intestines, and then makes its merry way through your digestive tract. And then along this route, you've got your bile duct and pancreatic duct that feed into that small bowel, so that when you consume your food, there's adequate mixing of those enzymes. So now after surgery, you see the portion of the bowels that are resected, the head of the pancreas, the first part of the small intestines, the gallbladder. And so everything is being rerouted. So now the stomach is reattached to the small intestines, and then that limb is brought back up to mate the remaining pancreas and bile duct. And there's two typical forms with the Whipple, whether or not the stomach is retained or part of the stomach is resected. However, there's still this limb here that is now where food contents empty into the small bowel. The enzymes and bile acids are emptying more proximally to where meeting with food. So that can create a little bit of a issue as far as nutritional challenges. So let's go over those challenges. So post-surgical changes, there's a poor delivery of enzymes and bile. So the asynchrony of where food contents are mixing with those enzymes creates a barrier to having adequate enzyme support to digest the foods, which then can lead to increased inactivation of enzymes. The pancreas is also responsible for secreting a substance to help neutralize the acidic environment from the gastric space to the small bowel space. So there can be increased inactivation of enzymes. And that is, of course, because of the resection of those parts. That can also then lead to decreased pancreatic stimulation. The pancreas also secretes a substance to help stimulate the pancreatic enzymes to be released when we eat. There's also potential change in food transit time. So how rapidly food contents empty your stomach into your small bowel. There can just be decreased timing allowed for those food to mix with the enzymes. All of these factors can increase the risk of malabsorption. What is malabsorption? It is essentially, in this condition, exocrine pancreatic insufficiency. You will hear me say EPI throughout. It's essentially the inability or decreased ability to break down and absorb the food that we eat. There's a pretty high prevalence following surgery, a pretty wide range, 56 to 100%. Even in inoperable or advanced forms of chronic pancreatitis, there's still a high risk of having EPI. So we're going to talk about how do we identify EPI. We have to talk about all of the details. Stool characteristics. I've got some beautiful charts to show everyone. If you have any unexplained stomach pains, especially when you eat, gas and bloating symptoms, urgency to have a bowel movement, especially in the middle of the night, or even after eating, some patients have just that rapid transit to where they're going to the bathroom quite immediately after meal intake. And then it's important to note, when did the symptoms start? Sometimes patients have maybe more milder forms prior to surgery, and they're even more magnified after surgery. And keep in mind that severe malabsorption can even occur in the absence of some of these symptoms. So these aren't all binding to where you have to have all of these to note EPI. So let's talk about poop. I tell my patients, we have to be detailed. I need all the details that you can tell me. So looking at your stool is really important. So identifying the texture. Are they loose, or are they formed, or are they mucousy or oily appearing? If there is an oily appearance in the layer of the toilet, or when you flush the toilet, can there be a little oily residual film in the basin of the toilet? Or are you having diarrhea? where they're just loose, watery stools. It's also important to note if your stool floats or sinks, bearing in mind that if they're floating, they might have more fat content, and that can indicate what's called steatorrhea. It's also important to talk about other characteristics. So the color of your stool. Are they brown, a normal brown color, or are they a lighter pale or beige color or clay colored? The lighter the color the stool, the higher degree of malabsorption. The odor, is there an overly foul smelling stool or just normal foul smelling? That can be relevant. So other symptoms. So what if you don't have any stool changes, but you do have gas and bloating or stomach pain, or you're experiencing ongoing unexplained weight loss? Those are all valid symptoms of EPI. Or if something was, if you had some labs done and were found to have certain vitamin or mineral deficiencies without any obvious symptoms, that alone can be a factor for EPI. So how do we treat it? So now we know the symptoms. We treat it with pancreatic digestive enzymes. These are critical to managing most EPI symptoms. So what these are a capsule that contain lipase that helps break down the fats, amylase, which helps break down the carbohydrates, and protease, which helps break down your proteins. Now, you do have other salivary amylase and other enzymes that further aid in the digestive process, but really the pancreatic enzymes are key in reducing malabsorption. And so it is important to effectively prescribe enzymes for those with EPI symptoms. So how do we prescribe them? Accurate dosing is so important. A lot of our providers that I work with are really great at adequate dosing or accurate dosing. However, there are still many providers that are just not as familiar with enzymes and often prescribe pediatric doses because they're just picking the smallest dosage seen. And so usually a starting dose that I recommend based on the guidelines that we have are about 50,000 to 75,000 lipase units with every meal, and about half of that with a snack. So if these symptoms aren't managed, then I start titrating the dose and increasing capsules with meals and snacks. Realizing there is a maximum threshold listed there, but the dosing range is really large. I have some patients that wind up taking a total meal dose of 150,000 lipase units. So every individual is different, and what their needs are going to be different. How do you take your enzymes? It's best to stagger your enzymes throughout your meal. I have some patients that take them all at the beginning or have been told to take it 30 minutes before, and those are actually may not be as effective. And so trying to stagger them throughout your meal so you were best replicating the flow of enzymes that is still somewhat happening endogenously, just not as well. We advise not to open and sprinkle the enzymes on your food. This can actually activate the enzymes too early. And so it's advised just to swallow the capsules whole. There are some instances where we'll advise opening the capsules and putting them in a bite of applesauce for those that are struggling to swallow the capsules or for other indications. So the dose can also change based on what you eat, especially if you go out to eat or there's a special occasion where you're eating something that might be heavier than normal, or you're having dessert after dinner, then it might require an extra enzyme. So other considerations, acid-reducing medications can be key. A lot of our patients are already taking these, but as I mentioned earlier, the pancreas also helps neutralize that stomach acidity. And if that isn't happening as well, then adding in acid-reducing medication can also help improve enzyme activity. If there is rapid transit, adding in medications to help slow down that intestinal motility can be very effective, especially for those that have had this procedure secondary to cancer and are having ongoing treatment. The chemotherapy itself can further magnify symptoms, so adding in those other medications can help. If the maximum dose is obtained and there isn't any further improvement in EPI symptoms, it's time to change to a different enzyme. There are 5 brand name enzymes on the market, and all have a different time release and pH release of activity within a narrow range, but so some patients can respond better to one over another. If there are still ongoing symptoms after a couple different enzymes that are tried, then it's time to consider other options or other conditions that could be going on contributing to symptoms, such as ruling out an infectious diarrhea or something that's called small intestinal bacterial overgrowth. Because of that loop of bowel that is needed to attach back to the bile ducts and pancreas, that can increase the risk of bacteria overgrowth. So treating that with antibiotics. And if there is rapid transit where you've got just hypermotility, then some individuals develop a secondary lactase deficiency. So following a lactose-free diet could further benefit controlling symptoms. What about vitamin and mineral supplements? So data is limited. However, there are reported deficiencies in zinc, copper, selenium, calcium, iron, vitamins A, D, E, and K, as well as vitamin B12. And this is because of the resection of the part of the small bowels and malabsorption that occurs. We often recommend patients take a standard multivitamin, if not sometimes a specific multivitamin for those at high risk of malabsorption. So what can I eat? Historically, it was advised to follow a pretty low fat diet to manage symptoms, but it doesn't treat the underlying malabsorption. It's otherwise just masking the symptoms. So no fat restriction other than trying to eat to what your comfort level is. I don't tell patients to consume overtly greasy or fried or fatty meals, but not to be super strict on fat content. If you're newly post-surgery, of course, it's important to consume small amounts, but frequently throughout the day of high calorie, high protein options, just to support your high energy needs in that phase. For longer term nutrition, if otherwise feeling well, you're on your enzymes and your weight stable, then it is a good time then to follow a mostly plant-based diet with healthy proteins, chicken and seafood or fish, maybe doing vegetarian meals once or twice a week, and otherwise minimally processed foods as far as a long-term approach. So in summary, talk about your symptoms. It is so important to not hold anything back about what you're experiencing. Even if you don't think it's related about your digestive symptoms, it's important to at least still tell your provider. Take your enzymes, and yes, this can be for the rest of your life. I recommend taking a multivitamin in most situations and eating to meet your needs. Meeting up with an oncology dietitian or otherwise a pancreatic specialist dietitian can be helpful. And annual lab evaluation to check for nutrient deficiencies to also further make other recommendations with supplementation needs, whether decreasing or increasing. That is all that I have. I will now pass it back to Dr. Gilbert.
Thank you so much, Ms. Bryant. That was a fabulous talk, very informative, and I learned so much, and I actually can't wait to maybe slip in a few questions at the end.
Sounds great.
Our next speaker is Dr. Adel Kardosh. Dr. Kardosh is a medical oncologist in the Division of Hematology and Medical Oncology, Knight Cancer Institute at OHSU. Dr. Kardosh focuses on gastrointestinal cancers, including pancreatic cancer, with an emphasis on translational research. Tonight, Dr. Kardosh will be talking to us about advancements in the oncologic treatment of pancreatic cancer. Dr. Kardosh.
Thank you, Dr. Gilbert. I hope everybody can hear me and you can see my slides. So today I thought about kind of taking an overview about where, at least from a medical oncology standpoint, where the disease it was, where the disease is, and where we're heading. So we'll go a little bit of a couple of slides talking about where the disease is today and how we got here. Many of you have seen these slides showing where there's an increase projected mortality rate for pancreatic cancer. And at some point, pancreatic cancer may overlap many of other cancers that seem to be the biggest cancers that we see. And then if you look at here in the SEER database, the estimated new cases for the biggest diseases tend to be in the high numbers, whereas pancreatic cancer still tend to be the 11th. However, when we look at estimated mortality, pancreatic cancer is at number 3 and closing numbers with colorectal disease. Now, the 5-year relative survival stands as is between last year and this year about 10.8%. One of the biggest challenges that I'm sure a lot of you have heard about is that we diagnose pancreatic cancer at a late point. And many of the patients that tend to be surgical patients, we call that localized, are only in a mere 11% of the patients that we actually find. Although when you look at the 5-year survival, these 11% are really the biggest group that tend to survive long. About 50% of the patients that tend to survive 5 years are the ones who undergo surgical resection and chemotherapy. Whereas when the majority of the patients that we diagnose, unfortunately late, about 50%, are these a patient whose disease have already progressed. Now, I can see how 10.8 is not a great number for us, and we're working very hard to change that. But when we look back in history over the past 30 years, if you look at these patients, you can see that about 30 years ago and even about 20 years ago, a lot of our patients were not getting adequate treatments. That trend is changing and changing fast, and that's a good thing. Where you can see the number of patients in blue who are now getting chemotherapy or surgery are exponentially rising over the past 30 years, where the numbers of patients that are not getting any treatments are declining. Similarly, in even metastatic setting, we see that even more and more patients are getting treatments, which is a good thing because we're understanding the disease, we're getting more information, and we're able to treat the patient not only in a sense of a curative intent, but all your palliation extends quality of life and symptomatic management for these patients. So if I take you back really to that 30 years, what have we done? How things have changed and why where we are right now? I think this is an overview of all the trials that have been approved and the treatment that we have gotten in an arsenal now with treating with patient with cancer. And you can see, if we look back at the 90s, the 5-year overall survival was a mere 4%. And we had one chemotherapy drug available to us. However, as we go through time, you can see that over every decade, we have worked harder and harder in actually adding to our arsenal, where we got more positive trial and more approvals. And now, 30 years down, we have more than doubled our 5-year overall survivals. Yes, it's still not perfect, still a lot of work to be done, but I think it's an encouraging view to see how much we're doing. And for the first time in 2019, we have moved beyond our backbone, which is chemotherapy, to approved treatment that are targetable therapy. These are treatment that target specific patient with specific mutations. So the field is definitely changing, and we're leading headway into changing how we treat these patients and how we were able to actually improve overall survival. That said, again, I would say that our backbone continued to be chemotherapy. From adjuvant perspective, meaning getting patients surgery and then follow that with chemotherapy, as indicated by the current trial highlight, or even starting with chemotherapy first, improving patients' outcome, improving patients who technically may be unresectable, getting him to a point where they can be resectable, hence improving their outcome and improving their survival. So there's a lot of work being done, even from a standard care treatments with chemotherapy, into kind of moving the field forward and improving patients' outcomes. That said, I think the biggest thing I would like to highlight is that things are changing and changing very quick, and changing because our technology is changing, our ability to understand the disease, not only as a one size fit all, but actually tailoring our treatments to every single patient that we see. Understanding the genetics, the environment that the tumor lives in, the way blood vessel penetrated, and the biggest thing nowadays is how the immune system engage with our tumors. So just a quick overview of very small number of things. I mean, this is just a small snapshot of things that we consider essential to move this treatment to become precision treatment, tailoring our treatment to individual patients. From a genetic analysis, we know that now patients with Lynch syndrome have an increased risk of developing pancreatic cancer, and they could be managed and followed and detected early. Also, we know for now that the majority of these patients seem to be sensitive to the current approved immunotherapy. So that's something that wasn't available to us about 10 years ago. Look at mutations like BRCA deficiency, or another mutations that tend to be cousins of BRCA that actually function in the same manner, and we can target the same mechanisms to inhibit the growth of these tumors. Looking at immunotherapies, again, we're able to analyze the changes in the tumor in order to utilize that change in a way where we activate our immune cells to recognize these tumors, as well as maybe developed vaccines and cellular therapies that target the cancers directly. Maybe not our own immune cells, but manipulating our immune cells that way to actually recognize these cancers. I'll show a couple of small examples in that. We talked about targetable therapy. Targetable therapies are ways that these drugs are able to target specific aspects of the disease, manipulating the environment, manipulating the gene, taking advantage of mutations that the cancer uses to grow in order to actually kill the cancer. So we're using the cancer's own advantage to our advantage and stopping it from growing. Changing the metabolism of these cancers. We also know now that the microenvironment plays a big role. Changing the feeding mechanism. The blood vessels are important to these cancer. One, from better penetration of treatment, right? If we're able to actually regulate the blood vessels to penetrate maybe better to the tumors, hence we can deliver our treatment better to the tumor, and at the same time, maybe stopping some of these blood vessels to further inhibit the tumor from eating and growing. So some of these things are becoming truly a reality. From an example, our BRCA mutation subpopulation, like I mentioned, we have the first approval of a drug, PARP inhibitor, olaparib, for patients who have received chemotherapy and have stable disease. Now they can be put on a pill where they can maintain their disease control. And this is not only for this. I mean, we have an increasing number of studies that are trying to target the same pathway, not only for BRCA, but for other mutations. Manipulating manipulating the blood vessels. That way, you can see here by manipulating the blood vessel and adding chemo and radiation, the response rate have become much more improved, and we're able to at many cases, make patients who are unresectable initially become resectable. But as a big overview further, now we're able to actually analyze the tumor beyond that. We can look at every single disease and analyze the specific mutations. We can target these mutations with many of our drugs that target the specific one mutation, or create combinations of these targets in order to truly inhibit the growth of these cancer and try to control their growth and their spread. Looking at the immune environment, looking at inhibitory immune cells as well as stimulatory immune cells. Can we change that? And can we utilize what we find in individual cancers into manipulating certain cancer differently from the other cancer? One patient gets certain treatment, the other patients get a different treatment based on what we're seeing inside their tumors. And to that, we actually have at OHSU a clinical trial looking at doing exactly that, where we do biopsies on the tumor in between treatments, and then we analyze the tumor, if you will, for every single assay that's available to us. And in that, we're studying not only the genetics, we're studying the proteins, we're studying the presentation of these tumors, we're studying the immune cells of these tumors. We're testing how chemotherapy affect them, whether it's in the dish or even in an animal model. And as we get all that information, we come up with combination to bring back to the patients in hopes that that combination will be a unique combination for that individual, and it will provide the patients a way to target these cancers. Further, from immunotherapy perspective, vaccinations have been a big deal. Looking at, now we all talk about, COVID vaccination, so we have more understanding of that, but there is ways to look at vaccination, not only by utilizing proteins and peptides the way we did. Now we have ability to manipulate the immune cells by introducing specific DNA and RNA, such as the current COVID vaccinations, in order to enhance the immune response and teach our own immune cells to target the cancer and stop it from growing and hopefully kill it. Certain cancers present high level of targets, such as mesothelin or a specific protein called RAS. These could be manipulated in a way to design specific cells to target them, or specific antibody to target them, or specific vaccination to teach our own cells to target them. So in summary, I think pancreatic cancer continues to be a challenging disease. However, there's significant improvements that we see currently in the field. From a medical perspective, new techniques in surgery that you guys will hear about, new abilities in imaging to detect tumors early on, new understanding of genetics to even monitor patients that are high risk of developing pancreatic cancer. Therefore, we can detect these patients before they develop the cancers and become spread. So that way we can offer truly curative intent treatments, as well as our own treatments in medical oncology by manipulating chemotherapy, immunotherapy, targetable therapy in order to get the patients exactly what they need. Looking at genetics, molecular immune, microinvariant, endogenetic, and technology. There's a lot more new technology coming in that is helping us to investigate the tumor and build new technologies for treatment. So I think this is a big overview. I'll be happy to take any questions that you guys might have. Thank you for having me. Thanks, Dr. Gilbert.
Thank you, Dr. Kardosh. It's really great to hear how many new treatments and different types of treatments we now have available, and kudos to you and your team for staying on top of it and pushing our innovations forward. Thank you so much. I'd like to move on to our final speaker. Dr. Rocha is the heading or chair and chief of the Division of Surgical Oncology at OHSU. He also serves as the physician-in-chief of the Knight Cancer Institute. Dr. Rocha's clinical practice encompasses all aspects of benign and malignant disease of the liver, bile ducts, and pancreas. He has been funded by ASCO and by the Cholangiocarcinoma Foundation. Dr. Rocha currently sits on the editorial board of the Hepatopancreaticobiliary Annals of Surgical Oncology, Journal of Surgical Oncology, and PLOS ONE. He has served on the NCI Pancreas Task Force, ASCO Gastrointestinal Cancers Advisory Council, and ASTRO Liver Cancer Guidelines Committee. He is currently the surgical lead of the International Cholangiocarcinoma Research Network and vice chair of the Southwest Oncology Group Surgery Committee. Now, Dr. Rocha is a surgical oncologist, and he'll be talking to us about the evolution of distal pancreatectomy for tumors of the left side of the pancreas. So just a friendly announcement that he has pictures and video of surgery, which I'm sure we'll all be very excited to see. Thank you so much, Dr. Rocha, for being here to present.
Well, thank you, Dr. Gilbert. Can everybody hear me okay?
Yep, we can hear you fine.
Good. And you can see my slides?
Sure can.
Okay, wonderful. All right. Well, again, thanks again for joining us here in the evening. And I guess some folks are out in the UK and it's early in the morning. So thank you very much. Let's see why I can't advance. Okay, great. Perfect. So what I'm going to talk about today is basically how we handle lesions in the body and tail of the gland. So if you see the picture on the right, you know, the pancreas is really made up of 4 different areas. There's a head, a neck, a body, and a tail, as well as the uncinate. So we'll typically talk about here as lesions in the body and the tail. And the reason this is important is because certainly when there's pancreas cancer in the body and the tail, they tend to present with larger tumors because there's not as much symptoms, or the symptoms can be nonspecific. When tumors present in the head, they press on the bile duct and cause jaundice, which is hard to ignore. For this reason, many tumors found in the body and tail of the gland are found to be metastatic when they are diagnosed. And it was thought that they had a worse prognosis. But when you actually compare the survival stratified by stage, there's no biologic difference that we know of between tumors in the head, body, and the tail. So what does that mean, though, from a surgical standpoint? Well, we know that when lesions are in the head of the gland, that major abdominal vascular invasion is a marker of more advanced disease with poor survival. So these are tumors that typically involve the mesenteric artery and the mesenteric vein. However, when you're doing a distal pancreatectomy or a left-sided pancreatectomy, the only vessels that are typically involved are the splenic vessels going to the spleen. And so these are routinely excised for both for margin clearance and for obtaining lymph nodes as well as the spleen. We do know, though, from pathologic studies that when the tumor does invade into the splenic vessels, the tumor does have a worse prognosis. But what we don't know is, can we predict that prognosis ahead of time, looking at the significance of radiographic involvement by things like CAT scan? So if you look at this is a very representative photograph looking at the splenic artery on the left and the splenic vein on the right. And you can tell it's an artery because you can see how thick the muscle is as opposed to the vein, which is quite floppy. But here you'll see there's tumor cells that are growing along the vein and the artery. And so what's next to the vessels is also the nerves. And as we know, pancreas cancer tends to spread along vessels and nerves. So this is a tumor that's got a bad prognosis. What does this look like on CT scan? Well, here you'll see some representative cuts looking at, starting at the top left, a splenic lesion, a pancreas lesion that where the artery and the vein are clear. Then moving to the right, top right, you'll see a tumor in the tail of the gland. I'll try to see if I can get my cursor. There we go. That's involving the splenic vein. Here, there's actually a tumor in the tail that's encasing the splenic artery, which you'll see lit up by contrast here. And then here, there's a tumor that's got occlusion of the splenic vein. So it's basically just wrapped around it. And you can see how the spleen is quite enlarged, and there's starting to be varices that are formed. So these are the different types of lesions that we'll see. So we wanted to look at this. So this is back when I was at my previous institution at Virginia Mason, looking at the significance of radiographic splenic vessel involvement in lesions of the body and tail. And what you can see from these survival curves is that we try to stratify lesions that had either abutment of the splenic artery or encasement or occlusion, and also of the vein. And what you'll see there in the survival curves is that tumors that had encasement or occlusion of the splenic artery did have a significantly worse survival, those patients, than those where the artery was clear. That difference was not statistically different when we looked at the splenic vein itself. We also then looked at the correlation of artery involvement and lymph node positivity, which again was statistically significant for splenic artery involvement, but not reaching significance for the vein. So it begs the question. These are the current NCCN guidelines looking at the characteristics of resectable, borderline resectable, and unresectable. And under borderline resectable, there's really not that much indication about splenic artery involvement, only in contact of the celiac. So it begs the question of whether splenic artery involvement should be included in the next round of NCCN. Well, what about more advanced lesions? So you'll see the pictures here on the left is a patient who had a locally advanced pancreas cancer. So again, beyond the borderline resectable, where you can see that there's tumor that's growing from the pancreas and wrapping around the celiac artery. This patient was treated with preoperative chemotherapy and had a good response, but you can still see how there's tumor around the vessels, even though the primary lesion has actually shrunk dramatically. So what do we do in these cases? Well, there is an operation that was designed a while back by a gentleman named Appleby, who was a Canadian surgeon. It was actually initially designed for stomach cancer. But what it involves is if the tumor is in the center of the pancreas and involving the blood vessels, the takeoff of the celiac artery, the operation actually involves dividing the celiac artery and dividing the pancreas, dividing the common hepatic artery, which goes to the liver. And you might think, well, how are things surviving? Well, it turns out that the pancreas has collateral blood flow. So there's an artery that runs from the mesenteric artery and loops around to the gastroduodenal artery. So this is how the liver would be fed, even though you're dividing the artery that goes to the liver. The stomach also usually has other collateral blood flow. So this is why this operation can happen. And it's now been called a DP CAR, which is the distal pancreatectomy with celiac axis resection. Well, this is the pictures that Dr. Gilbert was just referring to. So this is a patient who had a DP CAR that was done. And just to orient you, the patient's head is on the top and the feet are at the bottom. The stomach is lifted up. You can see the tip of the liver here. And here is the head of the pancreas, which is in situ. It's been stapled off. Here's the mesenteric vein going up to the liver. And then here is the common hepatic artery, which has been divided, as well as the celiac artery. The mesenteric artery is kept intact, and they can actually even see the left renal vein poking out. So the risk of this operation is that if the blood flow is not good enough, then you have to reconstruct. And so this is actually an operative video looking at a reconstruction of the common hepatic artery. And you can see those are being opacified by the contrast. So you can see here, this is actually an operative video trying to dissect all that tissue that's typically around the blood vessels, which we want to take with our specimens. So we're just carefully dividing these, and we actually take these very fine scissors, and you can see how we're spreading and dividing that tissue and then trying to free up the pancreas. It's already been divided. So now what we're trying to do is really make sure that these vessels are going to be the ones that need to be preserved are preserved, and the others we actually take with our specimen. Again, we're using the very fine scissors there to actually take all that tissue with the lymph nodes with our specimen, which is being retracted by the hand that you see in the picture. We're then looking at the blood vessels and figuring out where we're going to divide these blood vessels. So you can see them labeled there, the gastric, the hepatic, and then the pancreas. And then you can see that there's a clamp at the bottom. We clamp then the hepatic artery. Then the tumor is then excised on block with those blood vessels and then removed. And you'll see now the reconstruction. Now we need to take the end of the transected celiac artery and pull it over to the common hepatic artery. And here we use the help of our colleagues in vascular surgery to try to bring those two vessels back together. And there they are, sewing them. I'm just going to fast forward here to the end, and you can see there a nice pulsatile vessel now connected directly from the celiac artery to the common hepatic artery. And you can see the nice blood flow going through. And there you'll see a picture of the operative specimen with the tumor. So moving on, so that's probably the more maximally invasive surgery that we do. But you can also sometimes preserve some of the pancreas. So there is an operation called a central pancreatectomy, where we just remove the middle portion of the gland, typically at the neck. And this is reserved for more benign or low-grade lesions like pancreatic cysts, IPMNs, or even some well-differentiated small neuroendocrine tumors. You can see the diagram there on the right, where the tumor is in the middle of the pancreas. We just take out this middle section. Now, we can't take the two ends of the pancreas and put it back together. It's just not possible. So one option is to bring a loop of intestine and sew that to the remnant gland, and then make the GI tract back in continuity. Or another possibility is actually take that end of the pancreas and just put it right into the stomach and make a new connection of the pancreas to the stomach and have the pancreas drain that way. The advantages there is that you're preserving a lot of the pancreas, which is out here in the tail, which was healthy and normal to begin with, and you may improve on some of that pancreatic enzyme function that Amanda was referring to. I'll play another short operative video. Oops. The lesser set. Let me just turn that off. Okay. So this is, again, getting into the space. This is an ultrasound image showing the tumor that we see, and it's right on top of the mesenteric vein. So you can see how it's a smallish tumor, and we really would prefer not to throw away the rest of the gland. Here we are getting around the pancreas, and you can see there's just trying to feel around where the end is. There's a clamp. I can take a little tape to put around, and that allows us to kind of free up the space a bit. We use some energy devices to try and divide the connective tissue. I'm just going to move forward a little bit. And then here we are with a surgical stapler and carefully dividing the pancreas nice and slow in order to obtain our proximal margin. And again, then we lift up the pancreas that's going to be removed. And recall that the blood vessels, the mesenteric vein and the splenic vein, are all underneath. I then again use ultrasound to make sure I know where to divide the pancreas on the other end. So I have the tumor inside my specimen. And there you'll see pictures of the blood vessels being preserved and labeled there. We then take the specimen out, and it's going to be sent to pathology. We identify the pancreatic duct and put a small feeding tube in there so that we make sure not to occlude it with any sutures. And then there's the back wall of the stomach. So we put a couple concentric rims of suture. We then can make a hole in the back of the stomach, which we're going to use to put our pancreas in. Here's the front side of the stomach. You'll see there's a nasogastric tube in there. That's being pulled back. because that's just sucking out the stomach contents. And then we can pull the remainder of the body and tail of the pancreas through and just gently place it into the stomach. And we attach the pancreas to the stomach. We put sutures all around to really anchor the gland so it doesn't slip back out. The nice thing about this is that the enzymes can still be secreted, the insulin is being produced, and then we can close the close the stomach with the gland inside it. And there's the specimen, which is clearly contained. I'm going to talk briefly just about doing minimally invasive surgery with pancreas. And I think most of you may be familiar with the advantages, the smaller incisions, shorter length of stay, and some of the decreased morbidity. But certainly for a surgeon, there's a little bit of a disadvantage because you can't really lift things up like you used to. There's a learning curve, and it increases the operative time and cost. There's also some challenges. As you saw, the blood vessels that we're seeing there can be a little bit harder to do, especially with the other structures that are in the way, like the stomach and the colon. And there's always a question of, is it oncologically equivalent as the standard operation? More recently, we've used the Da Vinci robot to do these operations. Again, the advantage is there is that you actually see in high definition in 3 dimensions with 10x magnification. The surgeon has control of the camera and the instruments, and there's motion stabilization as well as ergonomic advantages. However, you do lose the haptic feeling, meaning you don't have a sense of grasping the tissue, and you need an assistant to change the instruments as well as dock the robot. This is the current system that's being used, which is the Da Vinci, and you can see the surgeon with their head in the console. This is a picture of one of my partners and I doing this operation with one surgeon at the console and the other surgeon, in this case me, helping to change the instruments out. And you can see the magnification in the screen to my left. When you look at the literature, and this is a bit dated now, but it's probably the best paper that we've seen, looking at multiple centers, you can see that with the minimally invasive approach, there's decreased blood loss, there's a decreased length of stay, and there's a suggestion of decreased complications. So those are the benefits. However, interestingly, our colleagues in the Netherlands did a randomized trial. So the previous study I mentioned to you was a retrospective study, which is somewhat contaminated with bias. So this prospective study called the Leopard trial was done in the Netherlands, comparing the minimally invasive approach and open approach. And what these seasoned investigators found was that there was really no difference in either complications, readmissions, hernias, fistulas, or even quality of life. However, as you can imagine, there was improved cosmetic results in the minimally invasive group. So I think in summary, what I presented you today was just a couple points. One is to consider neoadjuvant or preoperative therapy for patients with pancreas cancer in the body of tail, despite the fact that they're resectable. This is actually where we're moving in the field of pancreas cancer. Also to consider the more extensive DP-CAR procedure for advanced lesions that respond to preoperative treatment in patients who we think are appropriate candidates for that large of an operation. We also like to consider these parenchymal-sparing approaches like a central pancreatectomy in lesions that are appropriate and amenable. And then think about minimally invasive approaches when they are equivalent for cosmetic results, if that's of interest to your patients. Happy to take any questions.
Thank you, Dr. Rocha. It's incredible work that you're doing, and thank you for sharing those videos and pictures. It was really quite interesting. We do have some time for questions and answers now. So any of the members of our audience, if you'd like to type in a question, please feel free. I also do have just a couple questions for the group. The first one was for Ms. Bryant. And actually, it's one that I get a lot from my patients, and I'm really curious to hear your expert answer. If my patients ask, after a Whipple procedure, will I ever be able to eat normally again? And if so, how long is it going to take before I can eat normally?
That's a complex question with a complex answer. Eating normally can be different for every individual. But I tell patients to sometimes expect up to a year after surgery to maybe get back to some new normal, maybe. And it also depends on if they are going under further adjuvant therapy for cancer that can further delay any normalcy per se. But again, I've seen some post-Whipple patients that don't need any enzyme support and are otherwise eating fine, eating normally with no complications. But that's more of the anomaly.
Thank you. Dr. Kardosh, this is also a question that I have, I think about often. Do you think that we'll ever be able to successfully treat and cure pancreatic cancer without surgery with all of these amazing new medications that we're discovering?
Oh, tough question. Pancreas tend to be a different kind of disease than other cancers. We're starting to kind of see some data for patients who have specific mutations, like patient with Lynch syndrome, that might be amendable to immunotherapy. But I think we're a little bit way off, and the pancreas tend to be a different kind of disease with a lot of inhibitory immune cells, making immunotherapy, as great as it is, still a challenge. So hopefully one day, but not in the near future, I would say.
Okay, lucky for you, Dr. Rocha. Looks like we're still necessary. I actually have two questions for you. The first is, if you needed a Whipple procedure, would you want it to be the old-fashioned open surgery or one of the minimally invasive approaches?
So that's a great question, Erin. I'm glad you asked. So I think, we're always trying to push the boundaries. And I think it really matters on this is where the location of the lesion makes a difference. I think for what I just described, the distal pancreatectomy, I think we feel pretty good that the minimally invasive approach and the open approach are relatively equivalent. And so I think it almost becomes an issue of surgeon and patient preference and skill. I do think for Whipple procedures, and I know that there are some very, very talented surgeons that do that operation. I do think that it's, what keeps you in the hospital are the connections and not the incision. And I do think that we're not quite there yet. I think people, again, folks who are very talented do it quite well. But we did have a randomized trial that was done, again, by the same Dutch group that really raised some eyebrows as far as doing it for everybody. So again, I think if there's a center of excellence that does it well, that might be the way to go. If it was me personally, I would just have it done. I'd find the best person, the best surgeon to go to, regardless of the approach.
Sounds good. The other question I had, and this is really for all of you in a way, when patients are needing pancreatic cancer treatment, whether it's chemotherapy or surgery, what are some things that they should do to really prepare themselves to be able to get through these treatments, maybe as easily as possible?
I send them to Amanda.
Amanda, do you want to answer that one first?
Sure. Yeah, so definitely trying to optimize the patient's nutrition is hands down one tool that the patient has control over to have success, on top of other, of course, medication management to ameliorate any potential side effects of treatment. But if they're dehydrated or malnourished, they're not going to do well during treatment.
I tend to tell my patients that I'm a broken record when it comes to nutrition and exercise. Keep moving. And I ask about that every single visit, to be honest. I find that patients who are active eat better, and patients who are active and eat better do better overall. So I focus on that very, very heavily.
Yeah, I would echo my colleagues' comments. I tell patients that, an operation like a Whipple or any kind of pancreas surgery is really, I think of it as a space shuttle launch. I want all the conditions to be perfect. I want the patient to be trained like an astronaut and be fit and eating and have these, because it's really, you get one great shot at this, and you really want to be able to, and you know, we want to be able to have the best outcomes. And I have to make sure that when we're done with the operation, that they're still in good shape to then see Dr. Kardosh, because as we hinted around at this, we find that surgery is necessary for this disease, but is not sufficient. You know, we surgeons can only take out what we can see and feel with our hands. We cannot treat the microscopic disease. So this is where we need to really focus the efforts on the research front, develop new agents, harness the immune system, and that will make folks like Dr. Gilbert and I much more eager to take patients to the operating room.
Thank you all so much for your time and sharing your expertise and insights tonight. I really appreciate it. And, you know, treating pancreatic disease is so challenging. And I think, you know, the successes that I feel are really only because I have an incredible team like you guys to help care for our patients. I mean, really, it's such a team sport, and I couldn't be more honored to work with all of you. So thank you again very much for participating tonight. And I wanted to remind our audience that this video is being recorded and will be available on the NPF YouTube website. Any of the details, please feel free to log on and take a look. Thank you all very much. Have a good evening.
Have a good night.
Good night.